Hello, everyone. I am Dr. Grant Turek, and on behalf of the AADMD, I'd like to welcome you to our third Neuro IDD webinar. And without further ado, I'm going to give the microphone over to our moderator, Zach Taylor.
Hey, everybody. My name is Zachary Taylor, like Dr. Turek just said. I am a second-year medical student at A.T. Still University in Kirksville, Missouri. So my involvement with the IDD is, one, I am the director of service at our intellectual disabilities elective at our school. So we are one of a few of the medical schools in America that have a fully integrated, well, it's an elective for intellectual disabilities, and we get paired up with a mentor in our community that has an IDD, and then we kind of spend about 4 hours with them every month and kind of reflect on that, and we ask them questions how they like to be addressed at the doctor's office and things along those lines. And that kind of helps us tune our abilities, because a lot of doctors have issues with intellectual disabilities patients. And I'm also the head coach of our Special Olympics in Missouri. So that's one of my biggest time commitments, and I absolutely love working with the intellectual disabilities. So without further ado, I have the pleasure of introducing first Dr. Christian Brandt, who in January 2023 obtained a professorship in epileptology with a focus on disability medicine. It's important to note that this is the first of its kind in Germany, and the university Dr. Brandt works for is Bielefeld University. He'll probably have to correct me on that. This is where they see disability medicine, and it's one of the most important fields. In Dr. Brandt's own words, this is a major step forward in disability medicine. And also, we have Sybil Burmeister, which is the head of the German Epilepsy and Self-Advocacy Association executive. So without further ado, I will turn the mic over to our speakers.
Hello, good evening. Perhaps I do the first welcome words. My French is much better than my English. I'm very sorry about my poor vocabulary as well. My name is Sibylle Burmeister. I live in Ludwigshafen, which is near Mannheim and Heidelberg. Perhaps some of people in America know Heidelberg, lovely Heidelberg, and that's where I live. But the Deutsche Epilepsievereinigung, which is an officially registered organization, has his head office in Berlin, so in the capital of Germany. And I live in the south of Germany, as well as the other people from the board of directors of this association. We are a quite big self-help association. I suffer from epilepsy myself too, but fortunately, I have a full-time work. I work in a real estate agency. I am still in my office, and we see ourselves as the patient advocacy organization, and we are the German chapter of the IBE, of the International Bureau for Epilepsy. And I'm very pleased and very honored that I was asked to do some welcome words to this panel. It's a very big honor for me. And the Deutsche Epilepsievereinigung, the German Epilepsy Union, exists for more than 30 years now. I think it's 35 years. And we have our own day, Epilepsy Day. Yesterday, one day before, it was the International Epilepsy Day, but we have our German Epilepsy Day since 1996. It's always on the 5th of October. And we publish a lot of information material for the people who suffer from epilepsy and for their families, for example, or for their colleagues and something. And we offer it for free, not only to our members, but for everyone who is seeking advice about the epilepsy in Germany, in Switzerland, and in Austria as well. Even if they have their own organization, we have a lot of persons who seek for advice at the Deutsche Epilepsievereinigung. We are quite proud about it. We also publish a magazine which is called Einfälle. It's for our members only, but we invite everyone to become a member. And we are in relation to almost every other association who's dealing with epilepsy. So there are some kind of foundations in Germany, like the Stiftung Michael or the foundation who fights against SUDEP, this sudden death under epilepsy. And we all work together. We see each other on congresses, on seminars, for example. And that's very important that we understand each other, that we talk to each other. And as I already said, we live all over Germany. It's very much better nowadays that we have these things like Zoom, for example. We also offer webinars for people with epilepsy to inform them about new developments. We have, for example, next Wednesday, we have an evening about epilepsy and education on training on the job and studying, or we have a seminar about epilepsy in work life. And there's a lot of interest about this. That's making me proud as well. And we have, I think, one of the biggest problems for patients nowadays are the difficulties about the supplies changes. Excuse me, my English is very poor. About the supply chains, that we do not get the medication that we are used to. As I have a prescription from my doctor, I go to the pharmacy, and it's what they say to me is, sorry, there's nothing left from this medication you normally get. You just have to take another, the same pharmacological thing in it, but it's another, how to say, another surrounding. Perhaps Mr. Brandt can explain it better than me in English.
Well, it's another brand. It's the same substance, but another brand. Yeah.
That's it. Thank you. It's another brand, the same substance, but a lot of people with epilepsy are, are unsure about it and say it's not what I get normally. I won't take this pill, and so they get another substance, perhaps as well, from their doctor. And that's, I think, one of the biggest problems, and that we do not have some kind of advice centers nationwide. We only have these advice centers for people with epilepsy in our union state Bayern, Bavaria, but not everywhere in Germany. And that's one of the aims the Deutsche Epilepsie-Vereinigung has, as well as this education of the public about this illness, and that we have to fight against all these stigma which is connected to epilepsy. I see it myself. I'm very open. I always tell people, for example, my colleagues, that I have epilepsy and how they have to react if I have a seizure. And if you Google my name, you will find that I have epilepsy, that I'm working as a journalist, that I am in the board of directors of the German Epilepsy Association. So I cannot hide. But a lot of people with epilepsy are very afraid to tell others that they have this illness. But we did nothing to get epilepsy. I do not even know why I have epilepsy. There's nothing in my head to put it away. And so that's one of our aims. And in this medication progress, we would like to know more about the long-term side effects. I think that's one thing which makes people with epilepsy unsure as well, that there's always, yes, perhaps you get this illness afterwards. We have to take these pills for our whole life. And how about my liver, for example, or my kidneys, or perhaps also my bones? I think that's a big point too. And we do not only want to have less seizures, but we do want to have more quality of life also. I think that's one of the aims. And that's what we are fighting for, is the German Epilepsy Union or Association, as the Deutsche Epilepsie-Vereinigung. And now I'm finished. Thank you for listening to me. If you have any questions about me or the organization, just put it now or write it into the chat. I will stay a little bit with you, I think, but I wish you a very successful webinar now, and I will listen to you. Thank you.
Thank you very much, Sybil. So now we'll hear from Dr. Brandt.
Well, thank you very much. First to Seth Keller for organizing this webinar series, for having the idea. Thanks to Grant for organizing, and to Zach for moderating this this evening. Well, it's evening for me. For most of you, it's probably your lunch break, and I really appreciate that you spend it for this issue. And thank you very much to Sibylle Burmeister for saying her most important words. So these words would open a whole bunch of discussions, like the problems with the supply chain. And while you were talking about stigma, so we have currently a guest scientist from Japan at our place who will present tomorrow a cross-cultural study of self-stigmatization of people with epilepsy between Japan and Germany. And I'm very much looking forward to her talk tomorrow, but that's of course not my subject today. As Zach said, I work at Bethel Epilepsy Center, which is a huge epilepsy center with a tradition of more than 150 years, probably the biggest epilepsy center in Europe, and it's located in Bielefeld in North Germany. So I will try and open and share my screen. You should now be able to see my presentation. And I can say already now I have 2 polls during this talk. And so if you have your smartphones ready, or you can do it on your computer or laptop or tablet as well, and later on go to menti.com, menti.com, but I will show you later on. All right, so my main clinical and scientific interests are the work for people with epilepsy and intellectual disability, and anti-epileptic pharmacotherapy. So, that's a combination of both in my talk tonight. So the pharmacologic care of epilepsy in adults with epilepsy and intellectual disability. And these are my disclosures. Well, what are we going to talk about today? We have to ask ourselves, why are we just talking about the special population of persons with epilepsy and intellectual disability? So the questions are epidemiology, and we have to talk about special needs. I will introduce some study data on anti-epileptic drugs, or as they are called nowadays, anti-seizure medications in this group of patients. We will talk about general principles of treatment and about a few specific drugs, especially newer ones, and which are associated to orphan drugs and to, well, precision medicine. If that's really true to talk about precision medicine, or whether there is something in the future, we will see later on. And well, what are the appropriate outcome measures for the evaluation of treatment? And what's the role of shared decision making between doctors, other HCPs, and patients, relatives, caregivers, and so on. And of course, this talk will have a few conclusions. So, why do we talk about the special subgroup of persons with epilepsy and intellectual disability, or intellectual and developmental disability? So I just say ID normally because that's still the relevant term in Germany, but I know that other terms are well in existence. Well, this is a very old slide, or the data on the slide are quite old in modern medicine. They are from 2005, and they show that persons with, as it was called at that day, mental retardation. Well, I use the term because it was the term they used in 2005. 26% of persons with MR, or better say intellectual disability, do also suffer from epilepsy, which is opposed to around 1% in the general population who suffer from epilepsy. And if it is not just the intellectual disability, but a combination, for instance, of intellectual disability and cerebral palsy, then it's even higher. It's around 40%. I could have shown you another slide which would group the prevalence according to the degree of intellectual disability. And then it would go up to around 52% of persons with profound ID who also have an epilepsy. So for this slide, it's an important group of patients because there are so many of them. So, and there are special aspects of the prognosis of the epilepsy. So just look at the right side of this slide first. And this shows the prognosis of epilepsy in the general population. So how many persons with epilepsy will achieve seizure freedom? It's a very famous work. The first author is Chen from the group of Patrick Kwan. And they looked at the population of an epilepsy center in Glasgow, Scotland. And they looked at how many people were seizure free and what was the number of treatment attempts that brought seizure freedom. And what you can see here is if you look at the columns, 45.7% became seizure free with their first therapeutic regimen. When the first therapeutic regimen not work, they were put to a second drug, either in monotherapy or in combination, and around 12% became seizure free. In case the second drug didn't work, it was only 4% who became seizure free, and then well, the number decreases with the number of treatment attempts. And if you look at the cumulative proportion of seizure-free patients, then you will see that it is around 65% of persons with epilepsy who become seizure-free finally with pharmacotherapy. Now have a look at the left side of the slide. This was a cross-sectional study my colleague Bernd Huber did a couple of years ago. So he's a physician, a neurologist and psychiatrist for our long-term residential care unit. So he did a study on several hundred persons with epilepsy who lived at that time in long-term residential care at our place and assessed for seizure freedom. And well, 44% of those with learning disability were seizure-free at that time. And then the seizure-free rate declined with increasing severity of the intellectual disability. And only 22% of those with profound ID were seizure-free. Well, you can look at it from both sides. One side is, of course, it's a limited proportion of patients with ID who become seizure-free, and there's space for improvement. And on the other hand, well, it is at least 22% even among those with profound ID. So we have to do every effort to achieve this. Well, there are comorbidities and a high mortality. The mortality in persons with epilepsy, as assessed by the standardized mortality ratio, the SMR, is higher than in the general population, but it is markedly higher in persons with epilepsy plus ID or cerebral palsy. And well, important causes of death in the ID population are those two, pneumonia and SUDEP. And SUDEP, the sudden unexpected death in epilepsy, is something that we have to prevent by successful treatment of the epilepsy is possible, and by other measures if patients continue to have seizures. Well, we face, as you know, a couple of issues in persons with ID. Comorbid diseases may present in an atypical way. Patients may have limited ability to cooperate, problems with verbal expression, mental slowing. There may be the diagnostic overshadowing of comorbid diseases. And well, yes, the institutions, at least in our country, are very often, or in even most of the cases, not appropriately equipped. The staff is not adequately trained for the treatment of persons with ID. And hospital stays are distressing for every one of us, and even more for those with intellectual disability. Well, just going. All right. So now we are switching the focus to treatment. And well, treatment of the epilepsies consists of drug treatment, epilepsy surgery, rehabilitation, and psychotherapy. And yes, today's issue is the drug treatment according to my expertise, as I said already. A couple of years ago, Mike Kerr, who is a very experienced psychiatrist and epileptologist for persons with intellectual disability, gathered a group of persons working with this group of patients and asked them to rank their prioritized areas of interest. So where is the most unmet need? And just highlighting this, that 5 out of 11 top priority issues were related to treatment of the epilepsy, the treatment approach, adverse events, sedation, and well, drug interactions as well. So as we are talking about drugs, which drugs are we talking about? And there are quite a lot of them. So modern anti-epileptic drug treatment or anti-seizure treating started in 1856, 1857 with potassium bromide, which is still in use as a drug of further choice in many countries, in ours as well. Then 1912 phenobarbital. Then it's very slow curve of newly developed anti-epileptic drugs, the benzodiazepines in the 1970s, and from beginning with the early 1990s, it's sort of explosion of new anti-seizure medications, from vigabatrin 1992, lamotrigine 1993, just to the newest drugs, everolimus, cannabidiol, fenfluramine, and cenobamate. So we can choose among around 25 anti-seizure medications, which is good that there are so many, but well, it's not an easy choice actually. What does normally guide our treatment decisions in persons with epilepsy? Well, it's studies, it's clinical trials, it's multi-center, double-blind, placebo-controlled trials or other controlled studies. So some people are doing a Cochrane review every couple of years. And in 2015, they found 14 randomized controlled trials in persons with epilepsy and intellectual disability. Around 1,100 patients had been randomized into these 14 trials. And well, data shows the efficacy of the anti-seizure medications, and it shows the tolerability, shows that the tolerability of the drugs is similar to that in the general population. Let us please go back for a moment to the number of trials and the number of patients. So a pivotal trial for one new anti-epileptic drug may randomize 1,500, 3,000 patients, well, not 3,000 generally, but 1,500 patients just in one trial. And these were 14 trials with 1,100 patients in total. This is a discussion we can't go further into detail, because of course there are ethical questions if you include patients who cannot consent on their own into those trials. So there are good reasons for the many inclusion and exclusion criteria of these trials. But it means when a new drug comes into the market, that persons with intellectual disability have normally not been study participants. And so we can use this drug from day one on the market for a group of patients who we do not have experience with that from the studies. All right, but at least the authors of this Cochrane review say, well, although it's a very small number, it shows that data is generally comparable to persons with normal intelligence. Although many of these 14 studies are of limited quality in terms, they do not report seizure outcome, they do not report behavioral outcome, cognitive outcome, and so on. So yeah, there's still work to do with it. And some colleagues have done important work. And what I showed on the previous slide, the randomized, double-blind, multi-center, and so on controlled trials is just one side of the medal. The other side is the so-called real-world experience, which is gained normally by open-label studies. And there are open-label studies available for lacosamide, and it shows a retention rate of it's two studies one showing 62%, the other one 71% retention after 1 year, which means 72 or 71% of patients who have been put onto lacosamide are on the drug after 1 year. This is quite comparable to lacosamide data in general. And it's 30% after 4 years. So that means after 4 years, people have realized, no, lacosamide did not work or was not tolerated in the study population. There are open label studies for brivaracetam with a very low response rate. Response rate is normally the rate of people who experience an at least 50% reduction of seizure frequency. And which is important for brivaracetam, little bit more than 1/3 of patients experienced changed behavior under brivaracetam. The retention rate, once again, is comparable between persons with and without intellectual disability. There is also open label data for perampanel, which is a very potent anti-seizure medication as well. And it showed good efficacy and tolerability in just 20% of persons with epilepsy and ID. And this is, well, it's low figures, 90% for brivaracetam, 20% for perampanel. Of course, these studies have the limitations. Retrospective open label studies have the limitations, but well, they are one piece in this jigsaw puzzle of efficacy and tolerability. High withdrawal rate under perampanel and change behavior in 60%. I would like to draw your attention to the cognitive side effects of anti-seizure medications. And let's talk about topiramate here. Topiramate is a potent anti-seizure medication. I think it was introduced to the market in 1998. So it's one of the so-called newer anti-seizure medications, because it's all the drugs who came into existence from the beginning of the 1990s. So new anti-seizure medication, but well, a new one was around, with which we have 25 years of experience on the market now. It well has a mixed mechanism of action, and it is an anti-seizure medication with cognitive side effects. So that means around, I think it's around 25% of patients complain about word finding difficulties, or maybe the patients do not complain themselves, but relatives and family report those word finding difficulties. And we did a study on the question whether persons with ID experience the same cognitive side effects under topiramate as other people do. But well, how to assess these side effects? What you normally do is make a neuropsychological examination, establish a baseline examination, and then a follow-up examination. One very important instrument for this is the EpiTrack, which was created by German neuropsychologist Christoph Helmstetter from Bonn University, but it has been translated into many languages as far as I know. But well, that's an instrument which has been designed for persons of normal intelligence. So we as our neuropsychologists established a subset from other tests with examinations which we thought might be accessible for persons with mild, or in some cases also with moderate intellectual disability. It was we tested the domains of memory with story recall and digit span, executive functions, for instance, with the trail making test, attention speed, once again was a trail making test, and a naming test, which is from a German instrument called Aachener Aphasie test. But anyway, all of these are validated instruments. And well, it's not an epidemiological study. It's quite important to say that we did not assess how many patients had cognitive side effects. We just tested, do they have these cognitive side effects? Because, well, it's not a random population which I'm presenting here, but most of the people who participated in the study were referred to our center, and patients, relatives, caregivers said, please withdraw topiramate because our son, daughter, who else has developed cognitive side effects. And yes, we thought, apologies for that. I just said that I have some German subtitles here. This is a digit span. This is, well, the patients were asked to ask how so many animals in 1 minute as possible, so many foods. This is a trail making test, a psychomotor test, and it was very small numbers of included patients, but you can see significant differences. I just showed some significant results. The yellow column is without topiramate, and the red column is with topiramate, and you can see that these examinations were done significantly better without topiramate. So very important. Once again, it's a good and efficacious drug. Not everyone gets these side effects, but you have to monitor. And people who live in residential care who have an intellectual disability are endangered that cognitive decline might be attributed to a preterm aging, to dementia, and so on. So it's important to watch closely, to monitor closely the cognitive tolerability of anti-seizure medications. Well, what about behavioral adverse events? Do we think persons with ID are more sensitive to behavioral AEs? Well, yes, I think so from my clinical experience. And there are authors who found this. This is a study on around 200 children and adolescents. Adverse events were assessed for during the course of treatment. 67, so around 1/3 of the 260 children had an intellectual disability, and 28% in this group had behavioral adverse events as compared with only 6% in the non-ID group. And they made a correction for the higher number of ADs, and the difference was still significant. So yes, people with ID seem to be more sensitive to behavioral adverse events of the anti-seizure medication. Just to illustrate this, I would like to introduce a male patient with a Down syndrome to you. Well, this happened a couple of years ago, so he was around 55 at that time, I think, and so which is quite usual for a person with Down syndrome at this age. He had developed Alzheimer dementia, and with this dementia, there were tonic-clonic seizures and myoclonic seizures. So he had the low METs, the late onset myoclonic epilepsy in Down syndrome. And well, when he was admitted to our place, he was on carbamazepine 600 milligram, which is not an appropriate drug for this syndrome. First, we did not change immediately. We added levetiracetam in a very high dose, admittedly, and he showed aggressive behavior. All right, I will come back to that later on. We reduced levetiracetam, we added lamotrigine, and initially he had some hallucinations, but then we were able to decrease the dose of levetiracetam and established lamotrigine 150 milligrams per day, and the seizure frequency improved, and he was not aggressive anymore with this combination. So, well, this was a patient who experienced aggressive behavior under high doses of levetiracetam, and it's probably around 1/3 of patients with levetiracetam, as long as they have intellectual disability, who develop aggression. So that's a very typical side effects. And especially in persons with Down syndrome, I have seen behavioral side effects with much lower doses already with 250 or 500 milligrams of levetiracetam. So I think there is a high sensitivity to adverse effects in this group of patients. I would like to introduce you to another patient, a 32-year-old male who had a structural epilepsy due to perinatal brain damage. He had an intellectual disability with some signs of autism, and he had multiple seizure types. So that will not go into detail with that. All right, we will need this number later on. And he was on lamotrigine 250 milligram, highest serum concentration. He was on valproate, once again, really high serum concentration for an adult person. And we adjusted the drugs. We kept lamotrigine and decreased valproate a lot. So, and the serum concentration dropped as well from 104 micrograms per milliliter to 64. Well, what happened? We just reduced anti-epileptic drugs. So yes, his seizures became more frequent, but his alertness and his general quality of life improved a lot. So I would like to ask you, what would you do next in this patient? Please type menti.com on your smartphones, and I will have to stop sharing for a moment and change to Menti. Hang on a second. All right, I will start sharing again. And so I hope you can see the Mentimeter poll now, and please start giving your answers. I'm always curious if this works. Oh yes, it works. I can see one person answered already. So I can see, well, 13, 14, 15 patients have made, persons have made their votes. I can see we are around 130 persons in this conference. So I would actually like to get some more votes on that. But anyway, it's up to you. If you do not want, or if there are some technical problems, let's stay with this. We can anyway, we can see a clear tendency. So nobody would return to the previous dose, and 1/3 would keep medication unchanged, and 2/3 would opt for adding another ASM. All right, so can anyone tell me or give me a sign? Zach, can you give me a sign? Do you see my PowerPoint presentation again?
Yes.
All right, thanks. So thank you. So we kept medication unchanged. We discussed with the family, and they said, well, we can tolerate the deteriorated seizure frequency, but alertness and quality of life improved so much that we do not want to change anything. That's what I said. Initially, we have to find a shared decision with patient, family, other stakeholders. All right. So I would like to take a couple of minutes at the end of my talk for a few specific diseases. Let's say start with the tuberous sclerosis complex, which is a multi-system disorder affecting almost every organ in the body, lungs, heart, kidneys, skin, and so on. There are 2 known mutations in the TSC1 gene and the TSC2 gene. And we know the pathophysiological pathway of the disease, which is an overactivation of the mTOR protein complex. Around 80% of patients with TSC have also an epilepsy, and the disease is associated with neuropsychiatric disorders, TAND, neurosclerosis associated neuropsychiatric disorders, which manifest as behavior and psychiatric symptoms, is important proportion with intellectual disability and psychosocial consequences. These are some of the comorbidities: tumors of the heart, brain, kidneys, lungs, the thyroid, and the bones. Well, and we have a new anti-seizure medication for this group of patients since a couple of years. It's everolimus, which acts directly on the pathophysiological pathway of TSC. And it is a drug coming originally from, it's an immunosuppressant from its origin, which means we have to face, let's say, new side effects in our medical specialty. Well, this is placebo, left column, and then let's have a look at the right one, the high dose everolimus. One important adverse event under everolimus is stomatitis, 64% among high dose group as compared to 9% under placebo. Diarrhea, pyrexia, 14-20% as opposed to 5%. Cough. So yeah, and very important, nearly all of my patients who are on long-term everolimus have to take a statin for the treatment of hypercholesterolemia. But, well, I have started with the side effects, but you won't read every detail here. Just look at the columns of efficacy. The left column is a placebo, the middle one is the median dose, and the right one is the high dose. And you can see significant improvements of seizure frequency under the everolimus groups as compared to placebo. And it is a drug for which we have to assess serum concentration, because when a patient does not respond to a low dose and low serum concentration of everolimus, we have to increase and go to 9 to 15 nanograms per milliliter. The next syndrome I would like to highlight is the Dravet syndrome, named after Charlotte Dravet from France. Onset is within the first year or first 2 years of life. It's associated with multiple seizure types, and most of cases are due to an SCN1A mutation. And there are a few drugs who are licensed for Dravet syndrome. Stiripentol with contradictory data on the efficacy, fenfluramine, which has a serotonergic mechanism, and other AEDs are also efficacious. We have to avoid sodium channel blockers in this group of patients. And a new drug, well, licensed at least in Germany around 2 years ago, is cannabidiol. And of course, it has been tested in double-blind placebo-controlled trials in around 120 persons as an oral solution, 20 milligrams per kilogram body weight compared to placebo. And what you can see here is CBD led to significant decrease of median frequency of convulsive seizures, and to the improved 50% responder rate, and to improved seizure freedom as compared to placebo. Well, of course, the drug has possible side effects as well. Among my patients, I would say the most important ones are gastrointestinal side effects: diarrhea, vomiting, loss of appetite, and we have to check liver function regularly. Third special syndrome is the Lennox-Gastaut syndrome. It has multiple seizure types to include tonic or atonic seizures, atypical absence seizures, tonic seizures during night. There are specific EEG features. I actually will skip the next poll for the sake of time, so that we have still time for discussion. So what about cannabidiol in Lennox-Gastaut syndrome? Yes, it has also been tested in a double-blind placebo-controlled trial with 225 children and adults, two cannabidiol dose groups, 20 milligrams and 10 milligrams per kilogram body weight versus placebo. And once again, a significant median percent reduction from baseline under cannabidiol for both dose groups as compared to placebo. Well, the adverse events are, of course, comparable to cannabidiol in Dravet syndrome. I actually understand that the label for cannabidiol is different between the US and Europe. I don't think you have any restrictions for use in the US, while in Europe we have to combine cannabidiol with clobazam in Dravet syndrome and Lennox-Gastaut syndrome. Cannabidiol has also no license for tuberous sclerosis complex in Europe, and there is no need for this combination with clobazam. And there are pharmacokinetic interactions between cannabidiol and clobazam. I just want to mention that it's not just the new drugs like cannabidiol, which are maybe effective in Lennox-Gastaut syndrome. I would like to draw your attention to rufinamide, which seems to be let's say a weaker anti-seizure medication in general, but it has a proven efficacy against drop attacks against placebo. So that has also a license for LGS. And the newest of these new drugs is fenfluramine, which has been licensed for Dravet syndrome around 2.5 years ago in Europe, and just got its a new label of Lennox-Gastaut syndrome in Europe a couple of days ago. Yes, you can see here the reduction of convulsive seizure frequency per 28 days, and there were significant differences between two dose arms of fenfluramine as compared to placebo. Yeah, well, otherwise the drug would have not been licensed. And higher seizure reduction, higher responder rate, more seizure freedom, less frequent use of rescue medication, which may be very important for a patient not to get rescue medication so often, not to be too sedated. And once again, new drug, different mechanism of action, new side effects, loss of appetite, diarrhea, loss of weight, and sedation. Well, is it personalized medicine? Well, partially. Everolimus acts exactly on the pathophysiological pathway of tuberous sclerosis complex. I wouldn't say that all of the other drugs are really personalized medicine. Ketogenic diet in glucose transporter deficiency is personalized medicine, but there is still lots to do in the way of improve genetic examinations to do more genetics and find personalized drugs. Well, just right at the end of my talk to say, well, drug treatment is important, but it is important to embed drug treatment into comprehensive care, which we, for instance, do on our ward for disabled people. That's a German specialty that we still have the option to have people at the hospital for a couple of weeks, where we can combine medical and nursing care with specialized epilepsy nurses, with occupational therapy, physiotherapy, sport therapy, and as required, neuropsychology, psychology, and social counseling. So it's always important to see the whole patient, of course, not just the medication. In conclusion, persons with epilepsy and intellectual disability are a relevant group. Improved drug treatment is necessary for the group in general, which means more scientific achievements, and for the individual patient who is in the center of our care. Pharmacological care follows general principles of anti-seizure medication, anti-seizure treatment as in all patients. Try to avoid cognitive and behavioral adverse events, try to avoid interactions and enzyme induction. Several therapeutic options are available. Tolerability has to be monitored accurately. And well, that's you can see a photo of our center. And that's the final slide of my talk, actually. And well, thank you for your attention. And I'm open to questions, of course.
All right. Thank you so much, Dr. Brandt. We have 2 questions, which is about all the time we have. So that's perfect. So I'll go ahead and ask the first question. This comes from someone named Eileen. She says, how much of quality of life is improved if there's more seizures occurring? So with each seizure, there's a risk of injury and brain damage, correct?
Oh, yes. Yes, that's right. And it's, of course, well, yeah, that's a very important question. It leads to the issue that not seizure freedom is the most important thing in life, but quality of life. And of course, seizure freedom is the best thing to achieve. We know that seizure freedom is the most important brick to achieve quality of life. But if we look at the huge group of patients who do not become seizure free, then it's not the seizure frequency. It's not to have 10% more or less frequent seizures, but it's the tolerability of anti-epileptic drugs. So in someone who does not become seizure free, we have to do every effort to improve tolerability. Second thing is, if we know that someone will not become seizure free, just remember the decreasing of the columns in one of the first slides. Then we have to see how often is rescue medication being necessary, how many episodes of status epilepticus, how many E&R admissions, and then it can be very important to alleviate that and to do protection against SUDEP, night observation, and so on.
Absolutely. Thank you, Dr. Brandt. And the last question is, Michelle has a client with sudden onset of confusion, weight loss. She is on Dilantin for epilepsy. Could this confusion be from the Dilantin, even though she's been on it for the last 10 years?
Well, of course, it's always very difficult to answer a question for a specific patient without having more details. So Dilantin is, as far as I know, the American brand name of phenytoin, isn't it? Yes, thanks for nodding, Sis and Zach. So, well, the longer someone is on a given drug, the more unlikely it seems to be that a new side effects has its origins with this drug. But I would like to recommend to do serum levels, because I have seen many patients with increase in serum concentration of phenytoin who developed psychiatric side effects and confusion and so on.
All right. And we actually had one last question pop up. I think we have about 1 minute left. So is there a role for nutrition in managing epilepsy?
Well, I'll be very quick with my answer. So there is no nutritional therapy except ketogenic diet and the modified Atkins diet. And I think, but that would open a really huge discussion. The efficacy has been proven in a very small share of epilepsy syndromes. It's not a treatment for epilepsy as in general. If you talk about nutrition, every one of us has to use healthy nutrition. And that is important, as we know that many people with epilepsy, and especially with epilepsy and intellectual disability, do not have a healthy lifestyle. So there is space for general improvement if we talk about nutrition, but not that much with relation to the epilepsy.
Perfect. Thank you. I think that concludes, as far as I'm aware. There are no more questions.
One quick question, Zach. It's Seth Keller.
Absolutely.
If you don't mind, I'm actually I know Grant also a comment. I just want to thank you very much. I'm Seth Keller, one of the originators of this webinar series. And I really want to just personally thank Dr. Grant and Sybil, Zach, yourself, and Grant, and Courtney, and our AD&D colleagues and partners in putting this series together. We do have another webinar next month, and also this is available for CME. And I just wanted to one quick comment as this goes out. It is definitely about quality life and outcomes, and every seizure is very different in its complexity and severity. So when we really do talk about seizure control, what does that really mean, and how bad are the seizures? So I think one thing from my own practice here in the United States and what I do is trying to validate or objectify the severity of the seizures rather than a number count. I really don't want to count the number of events, but I want to have a gestalt. I want to have a value on how bad the seizures are to the person. Otherwise, if I'm just counting the numbers and my goal is to go from 10 down to 5 down to 1, what does that mean for the person? They might have a staring spell or something very relatively minor. So you have to really put it into the context of what these events are. Otherwise, the aggressive care or treatment could be worse than the problem. So it's always weighing all these things out. But again, thank you very much.
Thank you so much.
To kind of jump on the heels of what Dr. Seth Keller said, and to kind of answer one of the questions a little more with a little more information, the question about nutrition and managing epilepsy. We actually, the second webinar that we did in the Neuro IDD series was with Dr. Kenzie Cervenka and the GLUT1 Deficiency Foundation, as well as a nutritionist. So I would encourage you to go ahead and watch the second Neuro IDD webinar, which should be available for free on the One Voice network through the AADMD. And then not only would I like to thank you for joining us today, but I'd also like to invite you to our next webinar in the series, which will be the fourth. It is Neuromodulation and Surgical Care in Adults with Epilepsy and IDD. That'll be given on March 28th at 3 p.m. Eastern Standard Time by Dr. Eric Geller. So that's all that I have, and I thank everybody for your attendance.
Thank you again, everybody. Appreciate you coming on from the United States and across the world. It's been great. Thanks again, folks. Thank you. Bye-bye.